Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. In 2017, the journal Preventing Chronic Disease published Public Health 3.0, a call to action for public health to meet the challenges of the 21st century. Public Health 3.0 built upon the first phase of public health as it existed in the late 19th century and through much of the 20th, and Public Health 2.0, which was shaped heavily by the 1988 Institute of Medicine report, The Future of Public Health. Each of these phases was designed for the needs of its time. Now, the entire June 2024 issue of Health Affairs is devoted to the topic of reimagining public health. In an overview paper, Ross Brownson and Jonathan Samet call for transformational change that builds upon Public Health 3.0. What changes are needed to reimagine public health? That's the topic of today's episode of A Health Podyssey. I'm here with Ross Brownson, Stephen H. and Susan U. Lipstein Distinguished Professor in the Brown School and the Medical School at Washington University in St. Louis. Dr. Brownson was one of the authors of the overview paper in the June 2024 issue. We'll discuss his recommendations for a transformed public health system. Dr. Brownson, welcome to the program.
Thanks, Alan. Thanks for inviting me for this conversation.
Well, I'm looking forward to what I know will be a good conversation, and I should also acknowledge the broader role you played as an advisor in this theme issue. As we start, I'm struck by a phrase that appears in the paper where you said, the public health system is, I love this phrase, an optimistic misnomer. As editors, we're always looking for good turns of phrases. So that stood out for me. Can you say a little bit about what you meant when you called the public health system in the United States an optimistic misnomer?
Yeah, sure. Glad to do that. I'm glad the phrase caught your attention. So when we were putting this together, it struck us that while we always talk about a public health system, it's really more of a system of systems, or you could think of it as sort of a loosely connected set of entities that include obviously governmental public health, which was a lot of the focus of our article, but also community-based agencies, hospital systems, the voluntary organizations like the American Heart Association, American Cancer Society. But if you think about sort of the official governmental role of public health in the United States, there's a federal role, but a lot of the constitutional powers for public health spin off to the states. And so there you have 50 states and District of Columbia. You've got a wide variation in the health indicators in those states. And then you've also got a drastic difference in the per capita funding for public health, where at the high end, you're close to $400 per person per capita funded, and the low end, you're about $7. And so there's this really a patchwork of public health, and probably the patchwork's even bigger when you get to the local level, where there are about 3,000 or so local health departments. They're organized differently. Most of them are sort of decentralized so that the local health departments are autonomous. So that's probably 60% or so of all the local health departments. And then you've got another group that are actually part of state government, and then a group in the middle that are sort of mixed and shared. And the diversity across those is even greater, where you might have a small rural health department with, let's say, 5 to 10 employees, and then you might have the New York City Health Department with something like 7,000 employees. And so that patchwork, you could argue, sort of leads to innovation. People can do their own things, but it also leads to wide disparities in how services are delivered, the capacity to deliver services, and then just the different health challenges that each of these public health entities is facing. And that's sort of the backdrop why we came up with that term, the optimistic misnomer that you mentioned.
Well, I appreciate the description. Of course, we often also say that we don't have a health care system. And so you put these two together, and it's a reminder of the diversity of the country. When you wrote your paper, you said you were building upon the vision embraced by Public Health 3.0. I gave the briefest possible introduction to the evolution in thinking about public health, and I certainly don't want us to cover it in detail in a short conversation. But can you just walk our listeners through the evolution in the vision for public health from 1.0 to 2.0 and what Public Health 3.0 encompasses?
Yeah, sure. So if you think of public health as sort of a lifespan of about 150 years, and you go back to Public Health 1.0, that's the time when we were developing surveillance systems, mortality databases. We had advances in science like vaccines and antibiotics. We had other technologies that you might not think of as public health, like refrigeration. When we had refrigeration, then we could start having more fruits and vegetables for people because they could keep them for longer. And so those sort of early things happened probably the late 1800s to the early 1900s. And then we went for quite a period of time until DeSalvo and colleagues named Public Health 2.0, which started, I think, officially for them with the 1988 Institute of Medicine report on the future of public health, which the headline from that really was the disarray of public health, but there was a lot of deeper things in there, especially defining core functions of public health as assessment, policy development, and assurance, which has kind of become a mantra in a way for public health. And then you think of some of the growth of the methods of public health, methods in epidemiology, and then especially about in that era, the birth of the microcomputer that we don't always think of as another public health measure, but allowed us to capture data, analyze data, track things in a different way than it was before that. And then, as you mentioned, Alan, the Public Health 3.0 came, I think, in 2017 or so. And that really was building on those earlier phases, but was looking at also how do we engage different sectors than just governmental public health? How do we communicate better and talk about collective impact and the value of public health to our communities, and especially putting a focus on social determinants of health and health equity. There are a few interesting movements in that time period, the movement toward accreditation of health departments, which is kind of parallel to what we do in the healthcare system. And then the growth of things like academic health departments, which are formal partnerships between a public health agency and a university. And when there's a formal partnership like that, there's good data now that the performance in public health improves. So that kind of brought us forward. And then when John Salmon and I were putting this together, we first thought about, well, is there a Public Health 4.0? And then we thought, no, it's not really that. But our areas that we cover, and I think we covered 7 areas in the article, they tried to build in what we might call like Public Health 3.1 or something like that, which is sort of after COVID, what are some of the things that we're trying to address better and in a more deliberate way, which is a lot of what you talked about in that special issue.
Well, that's great. I like the idea of a 3.1 rather than the new version release of 4.0. So you're right. In your paper, you do discuss 7 areas to build on. And I think any listener who really wants to understand this is going to have to read the paper because there's a lot there. But it would be nice to just walk briefly through a few examples. You identify these areas of focus that the 7 fall into: contextual, topical, and technical. And what I hope we can spend a few minutes doing is sort of picking maybe one example from each, depending on how much time we have, and give people a sense of what you mean by these. So if we could just start with what you consider to be a contextual area, what does that mean, and what's one of the areas of focus from your paper that you think reflects those contextual needs?
Yeah, the contextual part we were thinking of is sort of cross-cutting issues that influence all parts of public health. So an example there could be how politicized and polarized public health has become. Public health has always been political because it involves policy, and policy is political by nature. But, we saw that amplified during COVID. We saw with public health measures like masking and vaccines and closing of businesses and schools, how politicized public health could be. And we also saw, as a negative thing, the trust in public health went down. I pulled up some data, and from early COVID to about 2 years later, the trust in CDC dropped about 30 points. And so that's a challenge because we have to have people trusting our governmental agencies in order to make progress. But it's not hopeless. There are things that are promising, finding common ground on certain public health issues. A great example there is opioid addiction. If you look at more conservative individuals and more progressive individuals, there's close agreement on the need to address opioids and even governmental support for opioid treatment and opioid policy measures. And so there are areas we can improve. The other important thing to think about with public health, I like to say all public health is local. If you look at trust in government at the local level, it's about threefold higher than it is at the national level. So if you're trying to really message and get the word out and address some of this polarization, working at the local level can often have bigger dividends than trying to work at the national level. It doesn't mean we shouldn't work at all levels, but local is a place where I think there's a lot of ability to message and to do good and set local policy and to bring in nonpartisan organizations to support public health. And we've seen some promise in approaches like that to address some of these issues.
Well, that's great, and it's very helpful to understand what you mean by a contextual area. So I want to also get a few examples from the topical and technical areas of focus. We'll discuss those and more after we take a short break. And we're back. I'm speaking with Dr. Ross Brownson about reimagining public health. We've been discussing how we got to Public Health 3.0, what the elements would be of maybe 3.1 if we're not ready for 4.0. And in the overview paper that Dr. Brownson wrote with John Samet, they present 7 areas of focus that fall into 3 categories: contextual, topical, and technical. We discussed the contextual example of politicization, but there are also topical areas that we need to move into that you describe. I wonder, again, if you could sort of select one of those and give us a sense of what you think needs to happen.
Yes, another topical area we talked about, one of them is equity. Sometimes people think of the term social determinants of health and equity. And in simplest terms, it's of having everyone having an equal opportunity to be healthy, sort of leveling of the playing field. And of course, during COVID, we saw how inequitable many parts of our society were. And that could be who was most affected by COVID. But then if you think about people in the workforce who are most exposed, who might be hourly workers, they didn't often have a chance to work at home the way middle and upper income workers might have. And so there were a lot of inequities that were exposed. Part of the movement of public health has been to make equity more of a core value or core mission for public health agencies. And that really starts within the agency, like what skills do our staff have? How diverse is our staff? How are we developing surveillance systems related to equity? But even more importantly, perhaps, how do we build new partnerships within local communities or states to work on equity and to try to level the playing field for everyone? And so that was one of the themes from the piece that John and I worked on. One of the interesting things, and that was also, there's a group in the Tacoma Pierce County Health Department in the state of Washington, and they've enlisted what they call participatory budgeting. And in that, they're really letting the community have a significant voice in how dollars are allocated, deployed, implemented, and then evaluated. And so they're innovative processes like that will probably never totally level the playing field, but they begin to share the power between the people who are trying to serve individuals in public health with those who are most affected by the health conditions that we're seeking to address.
Well, I can't help but use this opportunity to mention that we have a number of papers in the June issue that talk about alliances between communities and public health agencies, both in a sort of collaborative way as also in sort of a power building way. And it's really a rich area for further exploration. Your last area of focus was technical. There are clearly technical changes afoot. Maybe here again, you could give us an example.
Yeah, this is hard to choose one of these, but the one I'll talk about is communication, because it ties back to the 2 that I mentioned earlier. So communication on the positive side might be we get our message out effectively. We communicate about an epidemic or a pandemic going on. We know what will resonate with different audiences in society to get these messages out. So that's the positive approach that comes a lot out of communication science. The more challenging part is the mis and disinformation that came through during COVID. It's always been there. I think COVID amplified it. I think the previous one on polarization also amplified it. And honestly, social media amplifies it as well, because people tend to be in their own silos and practice what we call confirmation bias, that people are hearing what they want to hear from the same people who always put it out there. And so addressing that is one of the areas that John and I thought was very important. Part of this is to learn from communication science, how to talk about some of the positive aspects, some of the benefits that can come from public health, not always the negative parts of it. How to think about translating data into stories. People learn about things from stories. We love to read books, watch movies, listen to a good story, and we don't always do a great job of doing that. Around the misinformation theme, it could be identifying super spreaders of misinformation and countering those messages quickly. And they call it sort of flooding the zone, keeping as much accurate information out there. And then also building in trusted local messengers who can get the word out to advance public health at the local level. And so there are a lot of things that are being tried now, but also some that haven't been tried as much, that we were recommending that people ought to try out more and then evaluate.
So these are sort of areas of competency that are increasingly important in our current era. Well, so again, I think our listeners really need to read the paper if they want to get a walk through all 7 of the areas that you discussed. But let's change gears a little bit if we could. There's been so much discussion of the COVID-19 pandemic, highlighting the limitations of our current system, the need to reinvest, the hope that we get out of this sort of boom-bust cycle. I am curious now, from where you sit, if you see the pandemic as catalyzing change along the lines that you describe, or has it actually gotten in the way of some of the changes that you think are necessary, or maybe some of each? I'm just curious.
May I answer both?
Yes, you can.
Yeah.
Exactly.
Yeah, the problem is probably answers both. I think so. Let's start with the catalyst part. It showed us that we can move quickly on developing a new technology and deploying it, a vaccine. Most people that I saw were estimating, 18 months to 2 years to have a vaccine ready to go and deployed, and it was way shorter than that. So it shows that we can do it. Now, it took a pandemic to mobilize that, but on a smaller scale, I feel like we can do that as well. I think the other catalyst was more people know about what public health is. They know what epidemiology is. They know about that public health is important. When I orient our new students, I sometimes say that public health is the one good infectious disease, because it gets in your blood and you don't want to get it out, and good practices can spread, and we need you to spread those practices. And so those are the catalyzing forces that as John and I were hoping we can really build on. The barriers, we talked about those, the inequities that were there. If you look at the declines in lifespan from before COVID to post-COVID, the declines were dramatic for certain racial ethnic groups, especially for American Indian, Alaska Natives, and for Latino individuals and African American individuals. So we've got to learn from those and try to address those in a more systematic and forceful way. And then, of course, the politicized environment and the polarized environment that we talked about earlier. But I do think as a public health community, it did catalyze things. It puts a visibility on it. And that's why I think the special issue that you put forward is so timely, because we're in a moment of time where there's good agreement that something needs to change. And we have the tools to do that. We just need the political will. And, it's always a combination of political will, science, art, a little bit of timing, and perseverance that makes change happen. And I feel like that policy window is open now for that kind of change.
Well, I think that's a great way to view this right now. It is an opportunity to rethink some things that we don't tend to focus on. But whether we'll take advantage of that opportunity or not, or how we will take advantage of it, is actually still to be determined. Which raises sort of, maybe it's a variation on the same question, but As we bring our conversation to a close, I'm trying to figure out whether the evolution from Public Health 1.0, 2.0, 3.0, and the like, is this success or failure? And again, it's probably some of each. Are we always going to be in a cycle where when things seem calm, we underinvest, and then something happens, in this instance, the COVID-19 pandemic, and there's a call to action and some amount of action is taken, but maybe not enough, and our interest fades over time, and so the next shock to the system, we feel yet again underprepared? Or are each of these phases of public health sort of raising the bar and building a stronger platform? And sure, we aren't perfectly prepared for the next one, but we're a lot better prepared than if we hadn't learned our lessons, if we hadn't shifted from Public Health 1.0 to 2.0. And maybe we think of a certain amount of that cyclicality as inevitable, but we've actually buffered ourselves against it by improving the platform we work from. I know that's a pretty abstract question, but if there's anyone who I think can take it and run with it, it's you. So I'm going to hand it over to you.
Yeah, thanks. It's a great question. It's probably one of those unanswerable questions, but John and I, starting out this, I would say we were cautiously optimistic about some of the issues you talked about in the future. And then we had conversations as part of developing this piece with 9 public health leaders, state, local, national, red states, blue states, all over the place, really people who were very thoughtful. And it surprised us a little how optimistic they were. Even those who had been in the trenches through COVID and had faced some really big challenges. So I feel optimistic as long as we don't forget the lessons and we keep returning to those and we keep telling the story of public health so that we're more prepared for the next pandemic. And I think that can come through, I thought of at least 3 things where it could come for. One is just making sure public health remains visible, that people know about it, they know the value of it. One of the hardest things about public health is if you're doing prevention, you never see the events that you would have seen. If you're treating a disease and someone has a condition and they get better, it's very tangible what the outcome they've seen. But if you're doing prevention, you're reducing risk factors and someone doesn't ever get that condition, it's a lot harder to quantify that and make it visible. So I think we have to keep reminding people of that. I'm really always inspired by our students. There's a growing number of bachelor's degrees in public health and master's degree students in public health, and they're the future of this. And so the growth especially has been very rapid in bachelor's training in public health. And so we're just going to have a bigger workforce. We mentioned in our article that only 14% of the U.S. public health workforce has a public health degree. So there's a vast need for building the workforce. And then the third area I think is promising is just the new technologies we have. We talked about vaccine development, where we saw the value of telehealth during COVID, that we could reach populations that hadn't been reached before. Data science is moving at a rapid pace, and that data science can improve data systems, surveillance systems, how systems talk to each other. Because part of that, from your earliest question about the system, is we've got to get all these data systems sort of talking to each other and working together. So I remain optimistic about the future, and we have to be cautious that it's not going to be a straight line. It's going to be kind of a bumpy, windy road, but I think we're headed in a good direction now. Working in public health and talking with these public health practitioners, it's a gift to work in an area that can make people's lives better and healthier. And I think we ought to all remember that and keep moving forward.
Well, that's a great place to close our conversation. I think you capture the caution, but also the progress we are making, the improved understanding of the importance of making progress in these areas. It is a unique time where I would really agree with you. Even just sort of basic public awareness of what public health is has increased. And I realize we have trust issues and all of the others that you've described, but it is an opportunity to grapple with the challenges we confront. And as we tried to do in this June 2024 issue, Reimagine Public Health. Dr. Brownson, I appreciate your paper, your leadership on the issue, and your explanation of how you see the public health system as an optimistic misnomer, a phrase that will stick with me. Thank you for being my guest today on A Health Podyssey.
Thanks, Alan. I really enjoyed it.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.